Yes.
Good afternoon. This afternoon and continuing into tomorrow, I'm going to be giving a presentation on the UK guidelines that were available to clinicians in relation to the use of blood transfusion. Once again, it can't be exhaustive, but it will hopefully give a broad overview of the material available to clinicians from 1949 until the 2000s. I'll be going through general guidance that was available, as well as guidance specific to certain specialities. Again, inevitably, I can't cover the guidance for every medical and surgical scenario, and so this presentation will focus on those specialities in relation to which those who were infected by infected blood were treated. The overarching theme of the presentation is that the guidance was initially relatively limited. More recently, extensive general guidance and specialty-specific guidance has been produced. The reasons for the change over time is a theme that I anticipate we will return to on a number of occasions over the next few weeks as the inquiry hears oral evidence from various clinicians. But in this presentation, I'll address some of the more recent guidance to provide what I hope will be a useful counterpoint to the position during the earlier timeframe. The extent and nature of compliance with that guidance and what was understood about compliance is another theme that I will touch on in this presentation, and again, certainly something that we will be exploring with the oral witnesses as we carry on this week and next. And so we start with a document called the Notes on Transfusion for House Officers, issued by the Ministry of Health in 1949, and Sully's ahead of me, but for the purposes of the transcript, the reference is DHSC 0200152, and if we turn it to page 3, please. So we can see at the start that it's a Notes on Transfusion for House Officers issued by the Ministry of Health for the National Blood Transfusion Service in March 1949, and if we turn the page, it starts in this way: transfusion therapy should be undertaken only after careful assessment of the patient's clinical condition to determine the nature and quantity of fluid to be transfused and the rate of administration. The patient may require whole blood, concentrated red cells, or plasma. Then under the heading of choice of fluid, whole blood is used to restore blood volume or the oxygen carrying capacity of the blood, or to replace one or more missing elements of the blood. And then just below that in italics, blood is commonly indicated for 1, hemorrhage, acute or chronic, 2, anemia, acute or chronic, 3, oligemic shock, 4, blood deficiency states. Then secondly, concentrated red cells are ideal for the treatment of anemic states in which it's desired to raise the hemoglobin level and in which blood volume restoration is not required. That may be read, sir, to suggest that red cell concentrates at that time were to be used in situation where there was not acute hemorrhaging. And then at the bottom of the page, in relation to plasma, we see in bold text, plasma or serum should not be given unless the advantages to be gained by its transfusion outweigh the risk of transmitting homologous serum jaundice. And it asks us to turn to another section. And if we go to that section, it picks up on page 14 of the document, please. We can see the heading of this section, section 7, complications and dangers of transfusion. And we carry on to page 16, please, Sully. And the 7th complication and danger that's noted is homologous serum jaundice. And the section says this: this complication appears 40 to 120 days in up to 10% of persons receiving transfusions of large pool plasma and in 2 to 3% of persons receiving small pool plasma, and should be reported immediately to their regional transfusion officer. The jaundice is due to hepatitis, thought to be caused by a virus and may be fatal. Plasma should not therefore be used unless the benefits to be gained by the transfusion outweigh the risk of transmitting homologous serum jaundice. This complication may very occasionally follow the transfusion of whole blood. So you will have noted that the bold text at the beginning of the handbook relates to plasma, and here in relation to jaundice it's only mentioned that whole blood may very occasionally give rise to jaundice.
At this stage, do we know what small meant in relation to small pool? Because my general understanding had been that it meant not very much more than single transfusions, somewhere between 0 and 10.
Yes, sir. I recall reading the pool size. Let me see if I have flagged it, and if not, I'll need to look at it over the break. I can't immediately locate it in this document.
The question arises in my mind because if the risk is very similar to the risk of single donor donation, then, and it is here singled out for special mention, why should it be only very occasionally that the complication would follow the transfusion of whole blood?
Indeed, that's certainly something that you would need to consider. The logic doesn't entirely flow.
It depends really what small is in small pool.
It does, and apologies, sir, I can't instantly place it, but I'll look over the break.
Thank you.
That's the specific section on jaundice, but I want to track back in the document in relation to the use of transfusion. So could we turn back to page 6, please? We see the heading volume and rate of transfusion, and if we pick up the number 1, which addresses severe injury or acute blood loss, it says, in the presence of severe injury or acute blood loss, the rapid and adequate restoration of the blood volume is the immediate aim, and sufficient blood, or where sufficient blood is not available, plasma and blood in ratio 1:2 to raise the blood pressure to at least 100 mmHg should be given. In the previously healthy patient, a rate of 100 mils per minute will usually be tolerated, and then it goes on to the matter of the speed of the transfusion. Then if we turn the page, we see a heading in relation to treating anemia, and it addresses primarily the rate of transfusion, but then we see this in the final paragraph of the section. Ideally, no major surgical procedure should be carried out unless the hemoglobin is within normal limits. Pre-operative transfusions for anemia should be given an adequate time before operation to allow the full benefit of the transfusion to develop and to avoid the possibility of a reaction during operation. And it's the phrasing there, sir, that I would want to highlight, that surgery is indicated should not be carried out unless the hemoglobin is within normal limits. That's a theme that we'll pick up through the documents. The level of hemoglobin that's required before surgery, or indeed that post-labour in the obstetric context, transfusions are required. So here in 1949, it's indicated as needing to be within normal limits. If we then carry on to page 13, we pick up the heading Transfusion Records. A record of every transfusion should be made, preferably in the patient's case notes and on the special card or form NBTS 11 attached to the bottle. Such records should show serial numbers of bottles of blood and plasma. The recording of these numbers must never be omitted, since they may be the only means of tracing and checking a donor's blood if there is any question of incompatible transfusion or homologous serum jaundice. The latter occurs 40 to 120 days after transfusion of plasma or serum, or rarely of blood. And again, so it's that reference to rarely of blood. And it's not only important to be able to trace the donor bearing the infective agent, but also to be able to trace and withdraw other bottles of the same icterogenic batches of plasma or serum. Only by the careful and invariable recording of serial numbers on bottles of transfusion fluid can this be accompanied. All cases of homologous serum jaundice should be reported immediately to the regional transfusion officer. The necessity of accurate recording is not yet fully appreciated. And then we pick up at the bottom of this page. Every hospital should keep a record book showing the following details of all transfusions of blood and plasma. Whenever possible, the hospital transfusion officer should keep this record. In hospitals having no transfusion officer, it should be the duty of a responsible person. The book should show the date of transfusion, the full name of recipient, and then in Roman 6, the serial number of each bottle of plasma or serum transfused. So that was the guidance produced in 1949 for all, or seemingly given to all house officers, the most junior qualified doctors at that time. What is not present in this booklet is any reference to matters of consent from or information to be provided to a patient. Given the date of the booklet, that may be unsurprising, and its absence may chime with other evidence the inquiry's heard about the nature of the doctor and patient relationship at that time. We then have the 1954 edition of the Notes on Transfusion. I'm not going to go to it, but for the transcript, the reference is DHSC 0200153. In that edition, the guidance on pre-operative transfusions has been amended, and it's noted there that surgery should not take place unless a patient's hemoglobin is at least 10.4 grams, rather than the phrase normal limits. The 1954 edition retains the requirements to record transfusions that are given, but the bold text warning of the risk of jaundice and advising that plasma should not be used unless the benefits outweigh the risks does not appear in the 1954 edition. The discussion on jaundice is also shortened and simply highlights the need to report cases of homologous serum jaundice together with the serial numbers to the regional transfusion director. I want to then pick up and look at a book written by Mollison called Blood Transfusion in Clinical Medicine. We're going to return to various editions of this book to consider what was written. It's the inquiry's understanding that this was one of the core texts of the time dealing with transfusion in clinical medicine. The reference is RLIT 301567, please. And if we can turn to page 10, please. Could we turn it round, please? I'm hopeful it will turn. There we go, we're the right way up. This is the preface of the book. It doesn't specifically address transfusion-transmitted infection at this point in the preface, but it perhaps gives some insight into how blood transfusion was viewed by clinicians, and the preface says this: blood was once regarded as a fluid of infinite complexity, the very essence of life. The blood of each person seemed to carry in it the secrets of individuality. And then the next paragraph:
Well, I think you should follow on just for the sake of it. As recently as
1666, which doesn't seem terribly recent compared to 1951. As recently as 1666, it was natural for Mr. Boyle, in writing to Dr. Lower, to speculate in the following terms about the possible effects of cross-transfusion, as whether the blood of a mastiff being frequently transfused into a bloodhound or a spaniel will not prejudice them in point of scent. So the point I was actually going to pick up was the next paragraph. If each person's blood were as individual as this, transfusion would indeed be complex and would deserve to rank as the most refined branch of medicine. However, this early view of the subtlety of transfusion was eclipsed at the beginning of this century by the discovery that the blood of all human beings could be divided into 4 groups. It seemed that provided blood of the same group was transfused, one person's blood was indistinguishable from another's. Indeed, it came to be believed that people who belonged to the common group O could give their blood to anyone whatsoever. This point of view reached its widest acceptance in the early 1940s, when hundreds of thousands of bottles of Group O blood were given as a general panacea for the injuries of war, with remarkably satisfactory effects. As a result of this experience, a generation of medical men has grown up believing that blood transfusion is one of the simplest forms of therapy. And yet this view of the interchangeability of blood has to be reconciled with the growing knowledge of its immense complexity. And then if we turn the page, there's then an explanation of the book's purpose, and we pick it up in the second paragraph. In the next page, second paragraph, apologies. This book is thus composed mainly of an account of blood groups from a clinical point of view and of descriptions of the effects of transfusion on the circulation and of the survival of transfused red cells. It also contains chapters designed to fill in the remaining background of knowledge about the results of transfusion in man. So I just wanted to highlight that view from the preface and the linkages between the understanding in relation to blood linked to the impact, the effect in the war of having substantial quantities of Group O, and the suggestion here that there was a generation of medical men, as it puts it, believing that this was a simple form of therapy at that time. If we then carry on into the book, page 48, please. We see the heading Transfusion and Anemia. And bearing in mind the date of this book as 1951, we see this. As a general rule, transfusion should be used as a method of treating anemia only when the anemia cannot be cured by the administration of iron, liver, or other hematinics. The separate question, acute hemorrhage is dealt with separately. It must never be forgotten that transfusion carries risks which are large compared with those of conservative treatment. So as early as 1951, in relation to the treatment of anemia, Mollison's text is indicating that great care should be taken. Later in the book, I won't take you to it, Sarah, unless you'd like to see it. There is a discussion of the risk of homologous serum jaundice, and that risk is noted. In the second edition of Mollison's textbook, published in August 1956, the same warning is given against using transfusion to correct anemia, as is the warning given of the risk of homologous serum jaundice. An additional note is provided in relation to the appropriate treatment of acute hemorrhage, and I'd like to turn to that. The document is RCPE 30 2067, please. And page 52, please. We can see from the top right of the page that we're in a chapter headed Hemorrhage and Transfusion. And it's the other half of the page, please, Sally. Under the heading Restoration of Blood Volume by Transfusion, this is what's written. Blood volume can be rapidly restored by giving blood, serum, plasma, albumin, or some other plasma substitute. And then it addresses the use of transfused red cells. And at the bottom of this half of the page, it says this. There's a discussion about the studies which have dealt with the bleeding of dogs to establish the relative relationship between blood volume and restoring blood volume. And then it says this: however, there can be little doubt that it is a disadvantage to allow the circulating red cell volume to fall below a certain level. In acute experiments in dogs, Case Berglund and Sarnoff, 1955, found that when the packed cell volume was lowered from 49 to 32, there was no depression of ventricular function, but that when the packed cell volume was lowered to between 24 and 31, there was a definite depression, probably because at this level, coronary vasodilatation was already maximal. Clinical impressions suggest that hemoglobin concentration should not be allowed to fall below 9 grams per 100 ml, Grant and Reeve, 1951. Evidently, this is a minimum. The ideal should be to replace approximately as much whole blood as the patient has lost. A further reason for using blood rather than plasma in patients who have been traumatised is that the patient is less likely to develop a severe degree of anemia subsequently. It's a little unclear, sir, how a patient would develop a severe degree of anemia subsequently, or whether they'd simply have a degree of severe anemia which hadn't been corrected.
Yes.
But the point here is the reference to hemoglobin concentrations shouldn't be allowed to fall below 9, but the aim was to replace the full blood volume lost. We then return to the Notes on Transfusion document and the 1958 edition, WCAS 708, please. Uh, 608, apologies. Thank you. We see, Sarah, it's very much the same format, issued by the Ministry of Health in association with the Department of Health of Scotland for both the National Blood Transfusion Service and the Scottish Blood Transfusion Service. And then if we turn to page 3, please. We have the left-hand page. This edition of Notes on Transfusion, like the two previous editions, has been prepared by the Committee of Regional Transfusion Directors of the Ministry of Health. The booklet is intended primarily for use by medical staff of hospitals, and its purpose is to describe briefly some of the principles of the practice of transfusion and to suggest procedures. It is not intended that the booklet should supersede already established local practice and procedures without the agreement of those concerned. So 2 points arise, sir. Firstly, that the booklet is now not only, it seems, for house officers, but for medical staff more broadly. And secondly, the suggestion that it shouldn't supersede established local practice unless everyone agrees to do so. Then we turn to the second half of the page. Transfusion therapy should be undertaken only after careful assessment of the patient's clinical condition to determine the nature and quantity of fluid to be transfused and the rate of administration. The patient may require whole blood, concentrated red cells or plasma. A transfusion should never be given without a definite indication. Not only is this in the patient's interest, but supplies of blood are not unlimited. And with the ever-growing demand for blood, it is imperative that it is not used unnecessarily. And then if we turn to page 6, in the italics, halfway down the page, preferably no major surgical procedure should be carried out unless the hemoglobin is at least 10.4 grams per cent, at 70% haldane. If the hemoglobin level cannot be restored by appropriate medical treatment, pre-operative transfusions may have to be given. And that is the recommendation that's retained from the 1954 edition. And then if we turn on to page 9, transfusion records, we see the same first sentence as the previous edition. A record of every transfusion should be made in the case notes and if issued on the special card. And then this edition, it's not always appreciated that the main reason for accurate recording is the protection of the patient. We'll come back to a textbook from 1960, but whilst we're thinking about these notes on transfusion, it's worth noting that in the 1963 update to the notes on transfusion, an addition was made to that first paragraph that careful assessment was required before a transfusion should be given. And it states this: the use of transfusion to correct moderate or slight degrees of anemia that could be overcome as effectively, if more slowly, by other means, seems unjustifiable unless some cogent reason for speed of recovery exists. In some instances, failure to institute simpler and safer but equally effective treatment earlier leads to the quite unnecessary use of blood transfusions. And just for the purposes of the transcript, the reference for the 1963 edition is JPAC 40162_021. So at the moment, the written presentation that's been disclosed doesn't include that reference. It was missed. We will correct it and re-upload the written presentation to make sure that that reference is available for anyone who wants to look at that further. If we then turn to the in fact, we're not going to turn it up. I'm simply going to read something from it. Dr. Discombe's textbook, Blood Transfusion, A Guide to the Practice of Transfusion Within Hospitals. We have the second edition from 1960. We are seeking, sir, to obtain the first edition to identify if there's anything significant, but for various reasons we haven't managed to get hold of the first edition yet. The second edition is 1960. Dr. Discombe emphasises that hepatitis is a very important danger and must never be forgotten when assessing the need for transfusion. He also addresses the use of blood to correct pre-operative anemia, and he states, there is one very common use of transfusion, which to my mind is inexcusable. The use of transfusion to raise the hemoglobin of a patient just before operation, when in fact the anemia is due to chronic blood loss and could have been corrected by pre-medication with iron. This is very common in gynecological work, especially in the management of patients with menorrhagia caused by fibroids. In my opinion, every woman placed on a surgical waiting list should be treated with small doses of iron. For the transcript, that textbook is at RCSE 602. I want to move on then to an article published by Dr. Jean Grant, Director of the Oxford Regional Transfusion Centre, published in The Practitioner in August 1965. Could we have PRSE 303897, please, Sally? It's an article headed Complications of Blood Transfusion, and in her first paragraph, if we can just go down a bit, it says this: we have learnt how to avoid or minimise most of the unpleasant... Oh, just give that a moment. We have learnt how to avoid or minimise most of the unpleasant... I don't think we're going to manage to get any closer to it, so I hope people can read it on the screen. I'll try again. We've learned how to avoid or minimise most of the unpleasant general and local effects, but it cannot too often be reiterated that the safety of transfusion can be maintained only so long as there is a strict organisation of blood banking technique and unceasing watchfulness on the part of all who have a hand in the preparation of apparatus and the collection, storage, recording, labelling, matching, transporting and giving of the blood. The article then addresses a variety of complications of transfusions and the possibility of infection with hepatitis. And then in her conclusions, page 8, please, Sally. Dr. Grant says this in her conclusion: the practitioner should satisfy himself that it is really necessary to give blood and that no other treatment would be equally efficacious, even though it might take a little longer to achieve results. He might even benefit his patients by occasionally having the strength of mind to make the unfashionable decision not to transfuse. The hitherto healthy patient can well afford a 1 pint, half a litre hemorrhage without replacement. After all, as pointed out by Chassar-Moi, the blood donor himself lost a pint without anybody feeling that he ought therefore to receive a transfusion. We return then to Mollison's blood transfusion. At this time we go to the 4th edition, published in 1967. We won't go to the book because the key points that I want to highlight are spread throughout the book, but for the transcript, the reference is RLIT 301570. There are 4 points to highlight from the textbook. Firstly, Mollison indicates that patients with severe anemia as a result of recurrent hemorrhage have to be transfused unless it's reasonably certain that there will be no further hemorrhage. Where patients have had hematemesis and whose hemoglobin falls to 7 to 8 grams per 100 millilitre, transfusion is recommended. So that's in the context of recurrent hemorrhage. Secondly, he indicates in pre-operative situations, it's said that hemoglobin should be raised above 10 grams per 100 millilitres and ideally to within normal range, which would be 12.5 grams per 100 millilitres for women and 13.5 grams per millilitres for men. But the book also emphasises that many preoperative transfusions could be avoided if it were a routine practice to determine a person's hemoglobin concentration at the time when operation is first considered, as there would then more often be time to treat the anemia with iron, etc. Thirdly, in situations of hemorrhage, the recommendation is that clinical impression suggests that in injured patients, the hemoglobin should not be allowed to fall below 9 grams per 100 millilitres. Evidently, this is a minimum. The ideal should be to replace approximately as much whole blood as the patient has lost. We've seen that recommendation before in earlier editions. And fourthly, serum hepatitis is noted as one of the unfavourable effects of transfusion. It's noted to be a virus with a long incubation period and a wide spectrum of clinical effect. We will, though, then turn up the 5th edition of Mollison's book, RLIT 301573. It was published in 1972. And if we can turn, please, to page 30. We see the heading Indications for the Transfusion of Red Cells and the subheading Relatively Acute Situations. Anemia produced by a form of hemorrhage likely to recur. Patients who have developed severe anemia as a result of recurrent hemorrhage have to be transfused, so that's very much the same as the 1967 edition. They have to be transfused unless it's reasonably certain there'll be no further hemorrhage. It's most undesirable to allow such patients to become severely anemic, and for this reason, patients who have recently had hematemesis and whose hemoglobin is as low as 7 to 8 grams per 100 ml should be transfused. And then under the heading Pre-Operative Transfusion, there is evidence that when the PCV falls below about 30%, corresponding to a hemoglobin concentration of about 10 grams per 100 ml, there is some interference with cardiac function. Therefore, before surgery is undertaken, the hemoglobin should be raised above this level, even if only trivial hemorrhage is expected. And then the same recommendation, as I noted from the earlier edition, that pre-operative transfusions could be avoided if it was routine to check hemoglobin well in advance. If we then go on to page 82, please. We are picking up in the chapter on transfusion in oligemia, restoration of blood volume by transfusions or infusions. It starts in this way, it's just below that. In the treatment of hemorrhage, it is evident that a point must be reached where the number of red cells remaining in the body is so small that only whole blood can restore the patient. Nevertheless, in treating lesser degrees of hemorrhage, restoration of circulating blood volume alone is highly effective. And then over the page, we pick up on the top left corner, minimum acceptable hemoglobin level. We have the same words as before in relation to the coronary vasodilatation and the clinical impressions of hemoglobin not being allowed to fall below 9 grams per 100 ml. And then this addition, similarly, it has been concluded that losses equivalent to 20 to 30% of the blood volume, i.e. 1 to 1.5 litres in a normal male adult, can be replaced effectively with erythrocyte-free fluids such as dextran. So that is the guidance or the textbook indications from 1972. We then turn to the notes on transfusions again and the 1973 and 1975 editions. The written presentation erroneously states that these notes were produced by the DHSS and Welsh Office and not the Scottish Health and Home Department. In fact, both editions were published by the DHSS, the Welsh Office and the Scottish Health and Home Department, and a correction will be made to the written presentation in due course. If we can have a look at those, if we pick up the HCDO 40861, please. We're picking up the 1973 edition. If we turn to page 3, we see the same introductory note that was on earlier editions. And then if we turn to page 4, we see at the start of the booklet the same recommendation to take a cautious approach and the same warning in bold. That there needs to be a definite indication for a transfusion, and that the use of transfusion to correct moderate or slight degrees of anemia that could be dealt with more slowly would not be justifiable. Then if we move forwards to page 11, towards the bottom of the page in italics we have the same recommendation in relation to surgery, the need for a hemoglobin of at least 10.4. And then if we turn to page sorry, my notes are illegible. Page 18, we see the amendments that are made in this edition. Under the heading Transfusion Records, we have the same wording. A record of every transfusion should be made in the patient's case notes in addition to the details recorded in the transfusion laboratory. But in this version, in this edition, I should say, this text is in bold, whereas before it wasn't, perhaps suggesting that this recommendation had not been consistently followed and they were trying to draw this to people's attention even more. If we then carry on to page 23, we see a more substantial treatment of serum hepatitis and obviously a change in what is said about it, if I might just read that. Although the rejection of blood donations giving positive tests for the presence of Australia antigen or its antibody diminishes the risk of transmitting hepatitis, the methods of screening at present applicable do not detect antigen or antibody in every instance. Until more sensitive methods can be used routinely, the transmission of hepatitis will therefore continue to be a risk associated with the use of blood, concentrated red cells, platelets, fresh frozen plasma, cryoprecipitate, dried plasma, human antihemophilic globulin, factor IX concentrate, fibrinogen and thrombin. And then at the bottom of the page...
Just go on for a moment, to go back.
Human plasma protein fraction and human albumin are rendered non-icterogenic by heating at 60 degrees C for 10 hours. Human immunoglobulin prepared by ethanol fractionation is not icterogenic.
Thank you.
And then at the bottom of the page, cases of serum hepatitis, together with the serial number of the containers of blood and other blood products involved, must, as already recommended, be reported immediately to the Regional Transfusion Director so that donors can be investigated and any unused materials of the same batch may be withdrawn. And once again, so you can see that it is in bold perhaps to draw attention to the requirement to report cases of jaundice. I see the time, sir. There's just one more edition of Mollison that, if I might take you to, sir, before we take a break.
Yes,
simply
let's do
because
that.
then it's a rather tidier place to pause. Could we have RLIT 301569, please? We're now in the 6th edition of Mollison in 1979, and if we can turn to page 43, please. Apologies, I think I might have the wrong reference. Sorry, it's not 43, it's 34. We see on the left-hand side of the screen that we're in the part of the book dealing with indications for the transfusion of red cells. And if we pick up the next half of the page, we see the heading Pre-Operative Transfusion. And there is this. There is evidence from experiments on animals. We've read this before. It's the same as earlier editions about the coronary vasodilatation. That there is some depression of ventricular function. Then it says, on the other hand, oxygen extraction, central venous PO2 and coronary sinus PO2 remain unchanged until the PCV is down to about 20%.
Now, the PCV, that stands for packed cell volume, does it not?
It does, sir. Apologies, I should have made that clear. Packed cell volume. It's been suggested that a packed cell volume of 20% or more is acceptable in patients undergoing surgery in civilian practice, provided that cardiac, pulmonary, hepatic and renal function are normal and that there's a normal blood supply to the brain. Although most clinicians seem likely to continue to demand that their patients shall have a PCV of at least 30% before undergoing major surgery, it does seem that in healthy young adults there is little need to insist on a higher figure. So that's the change to Mollison in 1979. I'm about to move on to some specific Scottish guidance from the 1970s, so that probably makes it a good place to pause until we've had lunch.
Yes, well, we'll come back to that, shall we, at 2:05.
Thank you, sir.
So 2:05.